Welcome to the Reversing Type 2 Diabetes and Insulin Resistance with Lifestyle Medicine course. We're covering the key metabolic disturbances and the pathophysiology of type 2 diabetes and insulin resistance. My name is Dr. George Guthrie. I'm the immediate past president of the American College of Lifestyle Medicine, a family doctor with a lot of experience treating people with diabetes. I'm a certified diabetes educator and have enjoyed helping people make lifestyle change. I've been following this disease process for quite some time, and I enjoy having the opportunity to share this information with you. I trust you find it helpful. In this module, we'll be looking over the history of the last quarter century or so as we've learned more about this disease process. We'll be focusing especially on key articles and presentations through the years. I trust you'll find it instructive. So here are our learning objectives for this module. Number 1, delineate the cellular etiology of insulin resistance in type 2 diabetes. Number 2, recognize that the metabolic defects of type 2 diabetes are the expected physiologic response to caloric excess. Number 3, identify where a patient stands in the natural history of type 2 diabetes. Number 4, be able to recognize and clinically identify insulin resistance in muscle, adipose tissue, and liver. And number 5, explain how to clinically measure beta cell function. We have considered diabetes mostly a blood sugar disease, but now with our growing understanding, these other dimensions are very important. The mechanisms involved in type 2 diabetes and the metabolic syndrome are not anomalies in physiology, but they are the normal physiologic response to an excess of calories. As we go into some more of the details of how that happens, there may be some genetic and epigenetic differences between individuals, and certainly there are areas of the physiology that have varying responses between individuals depending on their environment and their genetics. But overall, the response is a normal physiologic response to excess of calories. Our next slide reviews the types of diabetes. We have type 1 and type 2 as the basic types. Type 1, the pancreas is not making any insulin, usually knocked out by an autoimmune response of some kind, and more common in young folks. As part of the type 1, we have latent autoimmune diabetes of adulthood, which is a much slower version. Often missed, but an important thing to remember as far as diagnosis is concerned. Type 2 has a kind of a different mechanism where there's insulin resistance and early high insulin, lower later. We call this non-insulin dependent, even when people are taking insulin to treat it. Maturity onset diabetes of the young is a genetic disorder that tends to hit young folks and is really a different beast altogether because there are metabolic mechanisms that are not functioning along the pathway of glucose management. And then gestational diabetes is often included and obviously related to pregnancy, but is also very closely related to type 2 diabetes as pregnancy tends to worsen the insulin resistance and cause the elevation in blood sugars. In order to understand abnormal physiology, we need to understand something about normal physiology. Below is a bit of my artwork to try to explain this. One will identify a busy cell there on the right-hand side. There's a stomach at the end of pectoral esophagus. And as you can see, the food comes down the esophagus, mixed up in the stomach, and is released into the small intestine. From there, it's absorbed into the blood vessels. Blood vessels go throughout the body. Some of them will go past the pancreas, And the pancreas will respond to that by making a messenger hormone that we call insulin. This is a normal physiologic response for a busy cell. As an illustration of this, I often use for my patients the story of my running a marathon. And I'm not a marathon runner, but I can pretend with them to be so. I have trained for several months. I'm well hydrated, carbohydrate loaded, and I'm at the starting line at 6 a.m., ready to go. The gun goes off, bang, and I start to run. As I run, the energy that is used is coming from some fat stored in the muscle, some carbohydrate, glycogen available. But with time, energy starts to be a problem. Mile 1, mile 2, mile 3. At mile 4, I come across a table with a sports drink on it, and I grab a bottle, take the top off, and I glug it down. It goes down into my stomach, into the small intestine, absorbed into the bloodstream, reaches the pancreas, and the pancreas releases insulin. Now, that insulin sends the message out to the cells of the body. My thigh muscles in particular have been doing a lot of work during this marathon, and when they get the message that energy is coming, insulin takes a message to them. Their response is a very aggressive, yes, I want it. We would call those cells very insulin sensitive. Now, during this very same race, the same body, same sports drink, the little eye blinker, the upper eyelid, is simply cleaning the windshield. And that same insulin comes to it, and its response is, well, okay, I'll take a little bit. And this points out a very important lesson that's missed by many clinicians. It's simply this: energy management is at the cell level. Each cell decides for itself how much energy it needs, either a lot or little, and then adjusts its insulin sensitivity. Thigh muscles are busy doing the race. They're very sensitive. The little eye blinker is simply cleaning the windshield, which is what it does. Energy management is not in the brain. It's not at the pancreas. It's not at the mouth. It's not in the blood vessels. It's really not at the pancreas. Pancreas is just responding to the sugars. It's the individual tissues which decide insulin sensitivity. And so there's absorption. And you can see from the little cylinders, the thigh muscles are very sensitive. And if we were to think about the eye blinker, it would be much less sensitive to the insulin. What is going on inside the cells is fascinating business. I first started to read about this from Jerry Olefsky's work in the 1980s. Found it rather exciting to notice that insulin attaches to the insulin receptor. And of course, there are changes across the membrane and a tyrosine phosphorylation of the interprotein moieties. Of interest is that chromium is necessary for that to happen and actually moves across the membrane at the response to the insulin. And then the IRS protein, and then the phosphoinositide 3 kinase activity, and then moving of the GLUT transporters to the cell wall, and then glucose transport by passive diffusion. Another thing to notice in this particular slide is the exercise in the upper left-hand corner. You notice that it can, by activating 5' AMP kinase, can also transport the vesicles to the cell membrane and allow glucose transport through the GLUT4 transporters. So it's a fascinating process, and understanding how that all works has been an interest of mine through the years. The body seems to know that high glucose in the blood causes problems. Through the years, clinicians and researchers have identified the problems coming from glucose in the blood as microvascular disease. In the eyes, of course, there's the blindness, inadequate blood flow to the retina, and the cells begin to send out signals saying we need more blood. New blood vessels are formed, which sounds good until you recognize that those are more likely to break. And blindness is often caused in Western countries by diabetes. Kidney failure, again, small blood vessel damage in the kidneys over time, leading to kidney failure. Nerves, neuropathy, especially the large nerves like the sciatic, have a small blood vessel that goes with them. And if that is impeded in some way, the blood flow, there may be some oxygen deficit, the nerves begin to complain. And we understand that neuropathy is the result, whether it's feeling of cotton or numbness or sharp lancinating pain, it's all neuropathy. And of course, if the circulation is poor, small break in the skin can lead to an infection. And because of poor circulation, the body is not able to eliminate it. Infection gets carried away, gangrene sets in, and amputation. So these are serious things that we would like people to avoid. The body would like to avoid that, and so it does its best to keep the glucose out. I had the privilege of listening to Michael Brownlee give his 2004 Banting Award at the American Diabetes Association. The article is listed for you there from Diabetes in 2005, The Pathology of Diabetes Complications. We have not always understood how they work together, but Dr. Brownlee has done a marvelous job at explaining how that works. So in the past, we knew that there was a polyol pathway, a hexosamine pathway, the protein kinase C pathway, and then the whole problem with advanced glycation end products as kind of mechanisms that were causing this microvascular damage. You know, different researchers were looking at different parts of it. What Michael Brownlee did for us was to put these all together into one kind of picture to help us understand it. And let's look at that a little more carefully. This slide should bring back some memories, even from high school biology, certainly medical school. The citric acid cycle is responsible for aerobic respiration and making the ATP that we need. Of course, the energy coming to it comes through pyruvate and acetyl-CoA as glucose is broken down aerobic pathway. So glucose starts out there at the top, and it can turn into the polyol pathway, sorbitol, into fructose, and that consumes some NADPH. It can be changed into fructose, which can then enter the hexosamine pathway, activates PA1 and TGF-beta1, which can cause their own problems. Glyceraldehyde 6-phosphate can release in protein kinase C activation, as well as the advanced glycation pathway and the things that come off of that. Advanced glycation receptors will pick up the glycated proteins and increase the reactive oxygen species. So what he did was to show that these things are all tied together, and as the Krebs cycle kind of gets backed up, these things are then forced through these four different pathways. Protein kinase C is probably one of our worst actors, where there's a whole kind of list of things that are activated: growth factors, inflammation, decreased fibrinolysis, angiogenesis, permeability, abnormal blood flow. There is a lot of negative effects. This next slide demonstrates an important point for us. You notice on the left-hand side we have glucose coming in and going down through anaerobic respiration to pyruvate, then acetyl-CoA, and entering the citric acid cycle or Krebs cycle. But notice also that lipids can come through the membrane, and the glycerol goes through pyruvate, the fatty acids go through acetyl-CoA. And so this problem within the cell caused by elevated energy levels is not just glucose, it can actually be caused by high lipid levels. Years ago, 1950s and 60s, it was demonstrated that you could give healthy medical students, whatever that means, high lipids and turn their diabetes tests positive. And this kind of explains how that works. Those lipids also can fill up the Krebs cycle. The increased reactive oxygen species from accelerated Krebs cycle feedback stop the pyruvate acetyl-CoA circle and then back up the anaerobic respiration, creating the problems associated with microvascular disease. So Michael Brownlee made this understandable for us. The biochemistry helps us understand it. The next part of the pathology of type 2 diabetes is sometimes identified as large blood vessel disease. And we correlate that in our minds as related to high insulin levels. Insulin, of course, is a growth hormone. It tends to make us put on weight, muscle, fat, and protein are all put in place with increased insulin. There is a strong association with high blood pressure. The exact mechanism is not 100% clear. We do know that insulin tends to increase sodium retention at the kidneys, so that could increase the volume of fluid in the vessels. We also recognize that it may be insulin resistance itself and the loss of endothelial relaxing factor functioning that makes the pipe smaller. At any rate, pressure tends to go up. Insulin also tends to increase cholesterol and LDL. It decreases HDL, or the good cholesterol, and of course, that combination of things really sets things up for a heart attack. The next slide shows the effects of insulin resistance, and we're reviewing it from just a little bit of a different angle. First is this mouth with a sugar cube. Of course, we remember that the muscle can take in glucose from the blood when it's exercising, and some of that sugar is going to go to the pancreas, which will then release insulin. And that insulin release will, of course, go to the muscle and put the sugar in there. If that muscle has insulin resistance, then the body's response is to make more insulin. Glucose is not the only pathogen or pathology here in the development of this disease, but high insulin levels are as well. As the insulin levels go up, we start to see weight sneaking up, we start to see the lipids moving up, and we start to see blood pressure going up. So this is not yet diabetes, but it's kind of step one. We really don't identify diabetes until we see the liver getting insulin resistance. Under normal circumstances, the liver in the fasting state is releasing glucose, either from glycogenolysis or gluconeogenesis, but it's into the bloodstream to supply energy for tissues in the fasting state. When the liver develops insulin resistance, it no longer listens to the insulin and continues to push glucose out. I don't know if you've ever had a patient say to you, as mine have to me, "I don't understand, doc. I did not eat a thing and my sugar went up." I explained to them that's because your liver has insulin resistance. The liver is not listening to the insulin, and it's continuing to make glucose even when you didn't eat it. So insulin resistance in the liver is when we really make the diagnosis of diabetes. We start to see that fasting sugar going up. The fasting blood sugar is a good reflection of the battle that goes on between the pancreas, insulin production, and liver insulin resistance. Another tissue that's involved is the lipid tissue. You will remember that insulin's effect on fat cells is to make fat stored. So the cell should get larger. If the fat cells develop insulin resistance, then they're not storing the fat, so that which is eaten is not being stored as efficiently. And of course, fat is also being released out of the fat cells. So the triglycerides and other lipids tend to move up. Along with that, unfortunately, the fat cells, especially those in the abdomen, are releasing cytokines, which are inflammatory and have negative effects on the pancreas, liver, and other tissues. Finally, we have the effects on the pancreas. Remember, step one is prediabetes or metabolic syndrome. Step two, when we have liver insulin resistance and we make the diagnosis. But step three in this process is really pancreatic burnout, for we now understand that over time, the islet cells begin to shrink. The islet cells of Langerhans will die off with normal apoptosis. There is supposed to be a replacement, as in normal people, from the pancreas exocrine side into the islets of Langerhans to replace those cells. Pluripotential cells should migrate over and take their place. This doesn't happen in the type 2 diabetic. Also, the cytokines from the fat cells may be inhibiting this. The amount of glucose in the blood, the glucose toxicity may also be inhibiting that process. But pancreatic ability to release insulin decreases significantly. And so, kind of this whole picture has grown from us. First, metabolic syndrome, and then kind of the quartet, and finally, we have Ralph DeFronzo, who's done so much work in the area of metabolic syndrome, received the Banting Award from the American Diabetes Association in 2008. He kind of added some others. So we've got the decreased muscle glucose uptake, we have increased hepatic glucose production, as we've talked about, and then the decreased insulin secretion. But there's also problems with hemolysis. The incretin activity has decreased. There's an increase in kidney glucose reabsorption, increased glucagon secretion, kind of the antagonist to insulin, helps to drive the sugar up, and then neurotransmitter dysfunction. The whole process, as we understand it, complex and snowballs to make things significantly worse in the bodies of those who are bothered with this disease. Beta cell function may be affected by age, genetics, lipotoxicity, glucotoxicity, and even amyelin secretion. Probably remember amyloid being part of the problem with some degenerative brain diseases, but the same thing can happen also in the pancreas. Myelin is actually secreted with the insulin out of the normal pancreas and has some role to play in managing the release of insulin and glucose. Incretins include the decrease in GLP and the GIP resistance. There are two incretins, GLP, glucagon-like protein, and gastric inhibitory peptide, which account for over 99% of the effects. Glucagon-like protein, or GLP, is released from the distal small intestine from the L cells. People who have type 2 diabetes tend to have a decreased secretion in GLP, and that decrease in GLP means that there's less stimulation of the beta cells, because GLP tends to strengthen the pancreas and increase even the number of beta cells. There's paradoxical rise in glucagon and, of course, an impaired suppression of liver glucose secretion, a significant distortion of what should normally happen. Of course, we have medications which can either come in as analogs or block the enzyme that breaks down the glucagon-like protein to help restore some of this function, but this is one of the effects happening. There's also an increase in the gastric inhibitory peptide resistance. It's released from the K cells, and this resistance means that the beta cells are more resistant to insulin secretory effects, and there's a glucose kind of toxicity effect. Another piece of this is, of course, the glucagon. Glucagon is secreted by the alpha cells, and it increases hepatic glucose production, as we mentioned earlier, increases gluconeogenesis from the liver, and the liver becomes much more sensitive and more likely to release this glucose. So glucagon becomes another important part of the pathology. Kidney function. Generally, 90% of the glucose is absorbed in the convoluting tubule. This actually goes up. You've got 10% of it in the segment of the descending proximal, the straight section. So the kidneys become more effective. And of course, we have medications which can help block this reabsorption to help control those blood sugars. And then, of course, there's the whole brain effect. The hypothalamus is supposed to inhibit appetite. We have the ventromedial nuclei and the paraventricular nuclei that are part of controlling this function. And as the weight goes up with insulin resistance, even with normal glucose tolerance tests, there is a decreased inhibition of appetite from these appetite centers. There's a delay in time even with increased insulin response, and we don't know whether it's cause or effect at present. It's just something that is noted. So when you have a patient in front of you, it's good to ask the question, where are they in this disease process, in the progression? In the past, we've used simply the fasting blood sugar and the A1C, but we have some other tools available, which we'd like to review here and possibly introduce to you for use with your patients. There's the 2-hour postprandial blood sugar, the HOMA, homeostatic method of assessment, both the insulin resistance and the HOMA beta. Of course, the fasting blood sugar, as we've noted before, and a stimulated C-peptide. So to look at these a little more closely to understand them, if we're trying to identify the physiologic response, recognize that an impaired fasting glucose is telling you mostly about liver insulin resistance. Impaired glucose tolerance, that is the ability of the muscle, the tissues to take up the glucose, would be in the 2-hour postprandial sugars. And then to actually look at beta cell function, we can use the HOMA beta testing. The HOMA testing, homeostatic method of assessment, can be quite helpful in understanding the patient. As an explanation, it's a mathematical reflection of the gold standard test, euglycemic clamp and the hyperglycemic clamp. And they go something like this. A person's blood sugar is held right at about 90 milligrams per deciliter, while an IV in one arm runs in insulin and in the other arm runs in glucose. From this, one can calculate a disposal rate for glucose. You can identify how much glucose goes in over a unit of time per some measure of body size, whether surface area or BMI can be chosen. And then the sugar can be raised to about 190, and at that level, the pancreas should be able to increase to meet that need. If it is unable to do so, then additional insulin needs to be added, and that additional insulin gives us a reflection of the inadequacy of the pancreas to fill what is obviously needed in the physiology. And from this, we have measures of both disposal rate and pancreatic function. The next slide is a review of the natural history of non-insulin dependent diabetes. This is a chart which I appreciated Dr. Ralph DeFronzo sharing with us in a lecture I heard from him several years ago, and I think you'll find it helpful. Notice that we have mean glucose plasma during an oral glucose tolerance test, the mean plasma insulin during an oral glucose tolerance test, and on insulin-mediated glucose uptake. Our subjects here are the control person with normal weight and normal glucose tolerance test, an obese person who has a normal glucose tolerance test, an obese person with glucose intolerance, and then an obese person with earlier diabetes with a high insulin state, and then the late diabetes type 2 with low insulin, also obese. So how does it look? So if we look at the mean plasma glucose during an oral glucose tolerance test, you'll notice that during the control group and the obese group, the amount of glucose under the curve during the glucose tolerance test is the same. Now, you start to see it go up with glucose intolerance. That's almost by definition, because glucose intolerance, that number goes up. And then, of course, it goes higher as the disease progresses. The next piece shows the insulin during this same progression. In the control, insulin is relatively low, but notice in the obese person, even though the sugar is normal throughout the glucose tolerance test, it took a lot more insulin to do that. That might explain why they're a little more obese. There's even more insulin secreted by the obese person with glucose intolerance. And then you see the pancreas function begins to drop off, and there's less and less insulin trying to put that glucose away. This last blue line shows the insulin-mediated glucose uptake, and of course this comes from that glucose clamp testing that Ralph DeFronzo has done so much of. Notice that the uptake is high in the control or normal person. As the obesity comes up, even though the glucose tolerance test is normal, you can see there's already a resistance developing. And of course, that resistance bottoms out and stays low through the other three areas: obesity, glucose intolerance, all the way through obesity, diabetes, low insulin, and of end-stage disease with the pancreas burned out. Appropriate treatment may best be given when we understand more of the disease. And I'd like to spend a little time going over with you this HOMA test. This is the homeostatic model of assessment. Insulin resistance, and you can see the formula there. It has a constant. It does pretty well at expressing, at least from a clinical standpoint, the ballpark of where the patient is. It's not 100% accurate, but it's close by. So the HOMA-IR expresses, is compared to a normal insulin resistance of 1. That is, 2 would be 2 times normal insulin resistance. HOMA-beta is expressed as a percent of 100% pancreatic function. So one might, for example, have somebody with a reading of 75% or 50%. And those that are high insulin producers may actually have 150, 200. I've seen as high as 300. At the bottom of the slide is the UKPDS website. You can Google the website, look for a website marked UKPDS that has the OX in it for Oxford. It's on that page, and if you will look for the formulas or calculations, it will be there for you to download. I would trust that you'll be able to download this onto your computer from the website. It can come as a small little program or as an Excel spreadsheet. I would trust that you'll be able to make use of it as you interact with patients. Certainly you'll need it for our next learning activity. So it works like this. You've got the fasting insulin or C-peptide. You have the fasting glucose. You feed it into the computer. The computer does the calculations, and it feeds out the response. It gives you a measure of insulin production and a measure of insulin resistance. Next slide is the normogram, which demonstrates how this works, the mathematical relationship. If we take somebody with a blood sugar of, let's say, around 200 milligrams per deciliter and a fasting specific insulin of around 200, and we run the lines, you find a spot and look up, and you can say pancreatic function is about 60% and insulin sensitivity is at about 20%. 20% would be about an IR of 5, because they're just the inverse of each other. 20% sensitive or 5 times as much resistance. The next slide shows what the little calculator looks like. You can see there's the place to put the glucose and the insulin. It comes up with English units, so you'll want to make sure you change those to the American units if you're living on this side of the pond. And then you choose either insulin or C-peptide off this little scroll down, and then hit the calculate button, and it should then calculate the number up for you. And some of the downloads we've had to do the changes manually, and then it will calculate, but it works fairly well either way. Let's put it into practice. John is a 52-year-old male with recent diagnosis of type 2 diabetes. He's not yet on any medications. His BMI is 43. His blood pressure 164/85. That sounds like there's some kind of metabolic syndrome going on. His LDL and triglycerides are up, and his HDL is down. Again, it sure sounds like metabolic syndrome. Fasting blood sugar of 130 and an insulin level of 35.4 microunits per mil. So put the fasting blood sugar and insulin levels in the calculator or spreadsheet. Make sure to use the dimensions appropriate to your lab. Calculator has the metric system units on the left, the imperial system units on the right. Notice you can choose to use either insulin or C-peptide on the pull-down menu. So what does it mean? Percent beta cell function, 137%. The pancreas is working harder than normal and pushing out extra insulin. This insulin and or the insulin resistance is driving up his blood pressure, lipids, and weight. He's early in the natural history of the disease and has a strong pancreas. He is a good candidate for lifestyle intervention. The same calculation can be done with the C-peptide. The dawn phenomenon happens when in the morning cortisol starts to go up as part of its diurnal cycle, and that it creates an insulin resistance. Because the C-peptide has a longer half-life and is not removed by the first pass through the liver, it is likely a better measure of the insulin function, insulin resistance, than the measuring the insulin itself. What about the percent sensitivity? 21%, the IR comes out at about 4.8 times normal. The sensitivity and IR are the inverse of one another. You can use whichever one you are most comfortable with as a measure of the combination of liver and muscle insulin sensitivity or resistance. In this example, the tissues are 21% sensitive. Normal would be 100%. Alternately, you can think that the resistance is 4.8 times stronger than normal. These can be tracked over time and used as additional motivation for patients. They also make good educational tools so the patient understands that type 2 diabetes is much more than a sugar disease. There is both appropriate and inappropriate use of the HOMA testing. And there's an article from Diabetes Care in 2004 which reviews this, use and abuse of the HOMA modeling. So inappropriate use would be measuring beta cell function in isolation. And to quote the article, the HOMA model has become a widely used clinical and epidemiologic tool, and when used appropriately, it can yield valuable data. Correlation coefficient is good, 0.78. Computer modeling for sensitivity via the euglycemic clamp, 0.87. Computer model on the resistance measured in the hyperglycemic clamp. So just like lipid testing is not 100% accurate for predicting an individual's likelihood of having a heart attack, and much more beneficial in evaluating a population. So the HOMA-2 calculation can be used as a motivational tool. Even though it's not 100% accurate, it does give us a ballpark of where we are and can help guide treatment and enable us to miss diagnoses at times. From the Wallace and Matthews and Levy article, quote, HOMA can be used to track changes in insulin sensitivity and beta cell function longitudinally in individuals. The model can also be used in individuals to indicate whether reduced insulin sensitivity or beta cell failure predominates. This would be especially important in identifying those older individuals that have their latent autoimmune diabetes of adulthood. Estimates of 20% and even higher of those diagnosed with type 2 diabetes may have this more autoimmune type of diabetes, and it's often missed by the primary clinician. When used in individuals, triplicate insulin samples should be used to improve the coefficient of variation. So this is a recommendation for individuals. It's not something I have done, but kind of watched over time. You may want to take this and put it into practice as the recommendation from the experts. The stimulated C-peptide may also be helpful in evaluating a person's pancreatic function. This is recognized as and used as a research tool. And what happens is the blood sugar for research is pushed up to 190, and the C-peptide is measured. So at that point, the pancreas should be putting out lots of insulin, and so the C-peptide should be up. If it's in the normal range, when the blood sugar is high, it's abnormal, and certainly if it's low. So that gives us another way of kind of measuring. I have a little experience with this from my past experience at a lifestyle center from South Central Oklahoma, where we had people for about 18 days and needed to know about their pancreatic function kind of early in their stay. And we would run their blood sugar up to 150 or above because we didn't want to kind of take the extra time or force the blood sugar up higher than necessary, and then measure that C-peptide shortly after they had taken in the meal. And these are the numbers that we used. A word of thanks to Charles Eno Marcel and David DeRose, who were my colleagues at the time and kind of helped to develop this and show that this is the way it worked for us in our institution. If the stimulated C-peptide over 150 was over 4 nanograms per mil, then there was 90% chance that people could come off insulin in the 2.5 weeks that we had them. If it was between 2 and 4, it was a 50-50. And then if it was below 2, it was quite certain that they would not be able to come off insulin. This allowed us to set expectations. This has not been published, but it is our experience, and it may be of some benefit to you in seeking to understand the pancreatic function of the patient that's actually in front of you. Understanding how the pancreatic function affects the diabetes and how it can be affected by lifestyle change is an important part of our understanding here. We have, to help us with that, a study that went back and looked at some of the data from the CardioPrev randomized controlled trial. The trial was looking at the Mediterranean versus low-fat diet, and out of the 1,002 people who were participants, there were 190 that had no drug treatment. So that was a good place to start seeing if measuring pancreatic function or insulin resistance could help predict whether the patient could go into remission or would progress on to need medication. As the authors looked at this, they defined remission per the American Diabetes Association by A1C, fasting blood sugars, and 2-hour postprandial, and looked at them over 2 years. They also measured hepatic insulin resistance fasting. They measured beta cell function using something called the disposition index, which is a mathematical approximation. And it was looking at beta cell function after a standardized meal. We'll talk a little bit more about that later. They used Cox proportion hazards regression and then followed for 5 years to see what would happen. What they found is reflected in this graph. So they took the high hepatic insulin resistance and identified that along with the low disposition index, that is, the pancreas was not making very much insulin, as one, and then compared hazard ratios as things changed. You can see the a high hepatic insulin resistance, as it drops, the likelihood of someone going into remission actually goes up significantly and to a statistically significant degree. When there is a high hepatic insulin resistance and a high pancreatic output, there's even a better chance that people will actually go into remission. But the very best category is with low insulin resistance and a high pancreatic output. This is consistent with the hypothesis Roy Taylor put forth, as we have discussed earlier.
Jubal is a 48-year-old female with a recent diagnosis of type 2 diabetes and is not yet on any medications. BMI of 28, blood pressure 134/82, LDL 135, triglycerides 185, HDL 45, fasting blood sugar 147, C-peptide 1.4 nanograms per mil. So calculate the HOMA numbers on your computer. So what does it mean? Percent beta cell function at 40.3%. The pancreas is not able to put out as much insulin as would be expected with that level of glucose. This person may have congenital beta cell weakness, have had damage to her beta cells from chemotherapy or pancreatitis, or have an autoimmune disease like latent autoimmune diabetes of adulthood. We don't know. We just know pancreatic function is low. Estimates of 10 to 30% of those who have been diagnosed as having type 2 diabetes may actually have LADA. Go looking for it if pancreatic function is low. What about the insulin sensitivity and insulin resistance? 77%, insulin resistance 1.3 times normal. This person does appear to have some insulin resistance in the liver, which is reflected in the elevated fasting blood glucose. To find out about muscle insulin resistance, check the 2-hour postprandial sugar. This person is likely to have a combination of a weak pancreas and insulin resistance. Knowing this might lead you to further testing, might impact which medications you prescribe. Those with a weaker pancreas, from whatever cause, are likely to have a much harder time responding, as might be expected, to lifestyle interventions and may actually need insulin sooner.
Measuring beta cell function is a real challenge clinically. There is really no test of beta cell function that comes close to the sensitivity and specificity of the HOMA2IR. So we've looked to other things. Listed here on the slide are really the main 4 possibilities. The gold standard is actually the lowest one there, the hyperglycemic clamp. It's quite involved and usually done in smaller research studies. The standard meal tolerance tests can also be used, and they're nice because it's kind of real world, and you get the incretins effect on the meal as well. So that, along with the oral glucose tolerance tests, are the ones that are usually used in larger research. The Matsuda index is an example of that. The Matsuda index uses a glucose tolerance test with glucose and insulin measures throughout the time of the test, and then puts that into a formulation so one can measure changes. But for a clinical standpoint, when you're actually sitting in front of the patient to really understand it, the HOMA2 beta is likely the best here. Now, correlation coefficient is about 0.69 up to maybe 0.72, depending on who you read. So it's got a pretty good correlation. Some recommend taking multiples and averaging them to find out what the truth is. But this is the easiest way for us to figure this out clinically. This is a rather interesting study looking at a plant-based dietary intervention and its ability to improve beta cell function and insulin resistance in overweight adults. It is a 16-week randomized controlled trial and is worth looking at, relatively recently accomplished, demonstrating that we're actually improving the underlying processes in type 2 diabetes. So it's a single center randomized open parallel study done on patients age 25 to 75 with a BMI between 28 and 40 kilograms per meter squared. It excluded people who had a history of diabetes, smoking, alcohol, or drug abuse, pregnancy or lactation, and a current vegan diet, because some of these folks were going to be assigned to the low-fat, plant-based vegan diet. 38, in fact. 37 would be assigned to the control. They were measured at baseline and 16 weeks, and the HOMA-IR was used to measure fasting insulin resistance, and then the feeding response was done in a functional sort of a way, as we discussed previously. So how did things come out? Well, as the weight came down, the HOMA-IR, the insulin resistance, the liver insulin resistance when fasting, fell in the intervention group. Now, a normal insulin resistance in the HOMA-IR would be 1. So people with increased insulin resistance might have 2, 3, 4, or 5, or decimal points in between. So on average, they dropped about 1 point in the HOMA-I measurement, and it had good statistical significance. That's encouraging. It correlated positively with the BMI changes and the visceral fat volume. So again, a good p-value. The change in visceral fat remains significant even after adjustment for changes in BMI. So that's encouraging. We get the sense that there may be even more of the visceral fat coming off. This is the fat that causes the most damage to us physiologically. And then the insulin secretion effect actually increased as the BMI came down. Good correlation coefficient, a p-value. We wish it was stronger, but at least it is in the right direction. There was a marked increase in meal-stimulated insulin secretion. This is a very good sign and supports the return of pancreatic function, consistent with Roy Taylor's hypothesis and intervention in which he showed the remission of type 2 diabetes. So in review, we have gone over the mechanisms of normal glucose response, and from that context, moved to the metabolic defects that happen with the development of type 2 diabetes, including hepatic and peripheral insulin resistance and that decrease in beta cell function. We follow the natural history of type 2 diabetes, with the pancreatic function actually going up at first and then coming down later, and that continuing increase of insulin resistance, both peripherally and in the liver. We've talked about how to measure insulin resistance and pancreatic beta cell function, and tried to convince you that you should use it in clinical practice. I strongly recommend that you download a copy of the HOMA2 Beta Calculator and use it in your practice to help understand where patients are and to help educate them as to their disease. For diabetes is much more than just a high blood sugar.
Thank you for your participation in the module.